Hello and welcome to the International Interprofessional Mentorship meeting. I am Dr. Kate Barlow, the founder and host for today's meeting. It's January 3rd, 2023, and today David Thomforde is here to talk about OTs Role in geriatric rehab. So please mute yourselves during the presentation, and you can unmute yourself whenever you'd like to ask a question, or you can type your questions into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please complete the survey link that I will be putting momentarily into the chat box. And at the end of the presentation, we will have an optional meet and greet, and I hope you will join us for that. So thank you all for coming today, and let's get started. David, thank you so much for volunteering your time.
Okay, thank you, Kate, and thank all of you for being here. As many of you know, I was involved in the program to begin with, and I haven't been very active lately, but I do recognize some names: Potin from Rwanda, Antonios, Emmanuel, and I'm glad to be speaking with all of you again. I do want to start out by saying that most of my experience, I've worked, most of my OT work has been in the United States. I've done some work in Africa. I've done some work in Asia. But occupational therapy really depends a lot on culture and country, because activity is really culturally based. So some of the things I say may be relevant to my experience, but not really relevant to what you find in your countries. And I hope if that happens, that you will stop, raise your hand or put something in the chat, and we can discuss things like that. If there's something that does not seem as relevant to your work, because it's very possible if it's not relevant to your work, that it's not so relevant to other people's work. So I look forward to having some dialogue, either in the beginning or at the end, if there are issues you want to discuss. But anyway, I have worked in geriatric occupational therapy for a number of years, both in rehabilitation centers and in home health. So I have quite a bit of experience in it. Anyway, let's get going then. So geriatric occupational therapy. So just in general, let's see, what am I doing here? I need to make this smaller on the side so the whole screen shows. There we go. Just as a definition, we're talking about occupational therapy, healthcare subspecialty, the functional needs elderly adults. And like any occupational therapy, we're dealing with activities, roles, medical challenges, social roles, but we're focusing on things that change as people get older. What is geriatric? The common cutoff age is 65 years, but geriatric is also it's almost a frame of mind. And it also depends very much on your physical status. So different people enter the geriatric stage at different times. So for instance, if you have a 90-year-old who's in good health and active, what I'm saying may be completely irrelevant. Whereas a 60-year-old who's retired and is poor health, we may be talking about somebody who needs geriatric occupational therapy. I also do know that I tend to speak too fast, especially when I'm excited about something. So if that's happening, or if I'm not speaking loud enough, please let me know. Why do we need to think about geriatrics and occupational therapy? Because in the US, and I imagine it's true in other countries, there are more people needing this kind of therapy because people are living longer. In most countries, we have improved nutrition, we have improved medical care, so life expectancy is getting longer. We have many, many more people who are elderly, over 65, even over 80, over 90. The numbers have grown to a great degree. And unfortunately, the aging process is not easy on the body. With the aging process, the body parts get older, they're less efficient, and you do get some diseases like arthritis, where joints wear out. You have heart conditions where The heart may not be as active, respiratory problems where the lungs are not as effective as they were before. So we do have more problems that people need rehabilitation, including occupational therapy. And also because of a lot of these problems, older people can have more accidents. They might have falls, they might have heart attacks, something like that. So there are more accidents that occur that result in more need for occupational therapy. And there are two things we can do in occupational therapy. One thing is we can say to an older person, how can we help you age more effectively? How can we help you avoid accidents? How can we help you deal with the aging process and maintain your independence to a greater degree? So we can do different kinds of training and activity modification to help that. But if somebody does get injured, then we can work on rehabilitating them because of the injury. If they've had a fall and break a hip, help them to start walking and doing household care activities, walking again. And then we can reduce the incidence of accidents. We can make them so they're less in danger of falling. So we have a lot of roles we can do with the geriatric population. So to begin with, how is it similar? How is what we do with geriatrics similar to what we do with other people? There are a lot of things that are the same. We still, use functional activities. We have the same process, the same treatment cycle, and we have the same focus on maintaining functional activity, maintaining people's individual dignity, maintaining their autonomy. We still work with, this is the same basic philosophy of occupational therapy as with other populations. But there are some differences. For one thing, older people are at a different stage of life. So I said before, they may have different priorities. And again, this will depend on the individual, where they are in the transition to becoming elderly. But most people towards the end of their life, they do have different priorities. As all of you know, to begin with, as a child, occupational therapy will focus on play. And then, because that's what is important for children, for adults, it's usually generating income generation to maintain a family and rearing children. And then when somebody moves on to a geriatric phase, there's more focus on leisure activities. Again, this is very much individually based. And it also is based on cultural situations. I spent some years in Uganda, and it was unfortunately the time when AIDS was a very big problem. And a whole generation of people in their 20s and 30s and 40s were dying. And it meant that the grandparents were raising the children. So you may have people in many countries who are in their 70s and 80s, and they're still, supporting grandchildren, raising grandchildren, supporting them financially. So, but in general, the focus of the elderly is on leisure activities. Also, going along with some of the changes in the body and the changes in the mind, there may be less flexibility. An older person may have more trouble learning new things, whether it be cognitive activities, whether it be physical skills. So we sometimes focus more on adapting to the environment, supplying adaptive equipment, changing the house, and less on changing the individual, whether that be strengthening, increasing ability to lean down, increasing balance. There's also, as people get to be elderly, there's also a more needs for end-of-life issues. And occupational therapists aren't the only ones that deal with this, but we can be very active in helping people deal with the end-of-life issues. And then finally, there's a large volume of life history. So when we're working with occupational therapy, we have many things the person used to do before that we can build on. Experiences we can discuss with the person, and we can incorporate them into our therapy. In addition, cases are more complex. An older person is more apt to have multiple diagnoses, COPD, along with heart problems, along with a hip fracture. So there may be contraindications for the individual diagnoses, and even more contraindications for the combination of diagnoses. somebody who's had a bypass surgery, so they had the surgery that opened up the chest to operate on the heart, but they may also have problems with walking, and you're not supposed to pull back on you're not supposed to pull the arms back because of the heart surgery. You're not supposed to push down because of the hip surgery. It really makes it more difficult. More medications. I don't know in some of your countries, but I've gone into people's homes where they would have a box and they'd have up to 20 bottles of medication. And the doctor had said, one of these in the morning, 2 of these in the afternoon, 1 time, 3 times a day, trying to keep track of all those medications. And medications, as though you all know, can cause problems. They can cause balance problems, cognitive changes, and then there's the interaction of the medicine. Now, at least in the US, occupational therapists are not directly involved in prescribing the medications, but we do have an important role to observe the person. And if we see problems that could be associated with some of the medications, to inform the nurses, to inform the doctors so changes can be made. We should have a good awareness of what the different medications the person's on could have an impact. As I said before, greater potential for injury. Bones have gotten demineralized, balance is poor. The cardiac and pulmonary issues may be greater. More vision and hearing impairments. Vision is likely to get poorer as the person gets older, or hearing impairments. More of those, more potential for injury. Again, and often less activity and less interested in trying new activities. The older person often has more difficulty with this. My father, who was very, very good at all sorts of things, he got into his 70s and computers came up, and trying to learn to operate a computer was just a different world for him. It was just impossible. So it's something I think he could have managed when he was younger, but coming it for the first time in the age 70, it was just too much. So more difficulty in learning activities, more difficulty in interest activities. Again, depending very much on the individual. I tried to do some research to say, do we help people? Do we help geriatric clients? And there's a lot of research out there. I just picked out a few. The first one worked on functional ability in basic ADLs in a geriatric ward and found out that the OT programs did make a difference. They improved things. The second one was working specifically with people with hip fractures, and those who received OT, I'm assuming in addition to PT and other services, had improved functional ability. And then the last one was specifically a fall prevention clinic, and there are OTs among all the different professions, and they did find a decrease in falls and also a decrease in fear of falling. And we'll talk about that later, but that is really an important part of rehabilitation after somebody doesn't fall, getting over the fear of falling. These are some ideas, some general ideas, and I think you're familiar with most of them in some ways. They're useful for any client with the different diagnoses that cause problems, but because older people are more likely to have the problems, they're more useful for elderly people. Changing the home, removing clutter, keeping pets out from under feet so you don't fall, more lighting, magnifiers so that with poor vision, buttons like light switches, slow dials in bright colors so you can see them, painting walls a light color, electrical outlets a dark color. Again, some of these things may not be relevant to where you're working, but there's some general ideas. Again, other color contrast. A person who's using a white plate on a white table with poor vision may have problems. Medication bottles. I mentioned somebody who had 30 different medication bottles. I remember one case going in and putting a green sticker on all the medication they took in the morning, a red sticker on the medication they took in the afternoon, a blue sticker on the medication they took in the evening. Doing something so the person will be aware when to take their medication. Another color contrast thing is painting edges of steps with a bright color. Walk-in showers, if you have that option, not stepping into a tub, putting a chair in the shower to a place to sit, grab bars, of course, in the shower throughout the home, ramps to get in and out of the house, non-skid surface on the ramp, non-skid surface, other places to get wet. And if you have the technology in your country, some sort of home monitoring system, so that a family member can be aware, know what's going on if they're away from the house, like with a television, or even a medical alert system, so the person who is the older person has a way of calling for help if there's a problem. So we talked about leisure activities, and these are things you do with all your clients, not just people with geriatric patients. But because geriatric patients are more focused on leisure activities, we'll talk about a bit using a modified interest checklist from the model of human occupation. It's basically just a long list of all the different things that are most common in the United States for people to take part in, and then there'll be a check saying, has the person done this in the past? Yes or no? Are they interested in doing it in the future? Yes or no? And if they haven't done in the past, are they interested in doing it in the future? Just to get an idea of different things that you might be able to work with people on leisure activities. One thing that is really important is to look at your culture and say, what do people do? What do older people do for leisure in your culture? As an example, I taught at the occupational therapy training school in Guyana in South America for a year. And there you would walk down the street and you'd hear this thing. And that was the sound of dominoes being hit on a table. Because in Guyana, when a person got older and they retired, especially men would sit outside and play dominoes. So if you can pick something that the people already do, you're much more likely to have success in working with that person on that activity. Some other examples are, things that have large print for people with poor vision. Sometimes, this domino game, the games that people played in Guyana were pretty complex, but there are simpler domino games that you could teach somebody. So if they have some cognitive impairment, they could play the games even if they're not up to what most people are playing. Simple things like raised beds for gardening. Plastic hoop embroidery is a very specific thing in the United States, I think, but it's basically a plastic grid, and somebody can use a needle and thread and make patterns on that. And it's much easier than doing the same thing on a piece of cloth. And if you're gathering people together, making sure they're physically accessible, if people want to learn to knit or want to continue knitting, using large needles and thread, large checkerboard. Checkers are popular in a lot of countries. Of course, leisure activities aren't all that we need to work on with geriatric clients. We do need to be careful. We need to be doing some balance exercises, although being very careful of falls, because older people are likely to have poor balance, and also more in danger of hurting themselves if they do fall. We can work on strengthening activities and exercises. I say strengthening, but actually more of the time we're working on maintaining strength and endurance, just because of the age of the person and because of problems that go along with aging. But again, if you can find things that are done locally, whether it be, farming, different activities that are relevant to the culture, you're more likely to be successful. And then there are all sorts of cognitive activities that you can work on with geriatric clients. I often deal with a memory game where you have a table and you put 6 objects on the table and the person looks at it, and then you cover up the things and you ask the person to say, what were they? Describe them. And I think there are some countries, I think I remember reading in Afghanistan that that's a game that people will play. So it's not only a memory thing, it's just something that people of any age play for entertainment. So things like that are interesting to come up with and work with people on. Again, focusing on maintaining the cognitive ability. Like with anybody else, your basic fine motor coordination exercises, ADL training, IDADL training, as I said, that is more difficult, especially some of the things like using a computer, ATM, a money machine, those cell phones are so complicated these days. I have a basic phone. I can't deal with a smartphone. Maybe I'm entering the geriatric phase, I don't know. But all these things are things that we can work on to help people improve as they get older. So let's talk a little about fall prevention, because it is so important as people get older. There's, the statistics are that a large number of people every year will fall and hurt themselves. And I don't want you to think that it's something only for OTs. It should be a team effort. OTs working on some aspects, vision specialists, medical staff, hearing specialists, people working together to reduce falls by treating visual impairment, balance impairment, mobility aids, training family members to know if a person is likely to fall, where in the house they're likely to fall, to be there to monitor and to assist them if they need it. And then, of course, as we said before, working on strengthening and endurance active deficits and the cognitive deficits, all that can help reduce falls. Again, things all you guys are familiar with are home modifications to reduce falls. So places aren't slippery, people don't trip. Energy conservation. This we work on, to a large degree with people with endurance issues. But as people get older, energy gets more difficult. Jobs get more difficult. If we can simplify the work, figure out what tasks, if the client says, if the family member says, well, my mother always falls in the shower, what can we do in the shower to help her modify it? Or my mother, tries to get in the stool to reach stuff off a shelf. Is there somebody else who can help them, or can we put the things on the shelf lower down? Simply sitting rather than standing. You can focus on the activities more, and you can reduce the risk of falling. Having a rest schedule, appropriate activity, so that they don't get tired out and fall because they're tired. And again, talking more about medication is thinking of the things that might be causing falls because the person gets dizzy. And talking with the doctor, okay, this medication is making my patient dizzy. What else could they take? How can we reduce the risk of falls that way? And then simply reducing, doing a dietary review, working with dietitians on that, so that if there is sufficient calorie intake. Again, speaking of my own experience going out, and when my mother got sick and she was the one always did the cooking, and all of a sudden my father was the one responsible for cooking, and he would open up a couple of cans of vegetables and they would have that for a meal, and that was insufficient calories, and that can result in more falls. As I said before, fear of falling can be really important. Again, to bring my own experience and my own personal experience in, my mother-in-law was very active into her late 80s. At one point, just getting out of bed, she had a dizzy spell. She fell out of bed, landed on the floor, broke her pelvis. Basically, ever after that, she, the breakage was painful enough, so she didn't want to fall again. And her solution to not falling was not to walk. But of course, it's a downward spiral, because when a person doesn't walk, they get weaker. Therefore, it's more difficult to walk. Therefore, it's scarier to walk. Therefore, they get weaker and more danger of falling. So you really need to focus on helping people overcome that fear of falling. Cognitive behavioral therapy, it's probably something that some of you are familiar with. We can't go into much detail about it, but it's something it would be interesting to learn. but basically it's a way to help people block negative thoughts of failure rather than, I'm going to fall, I'm going to fall, I'm going to fall, but, help me, I'm going to fall. Facilitate positive thoughts. I'm up, I'm walking, I feel good, I'm getting stronger. It's effective. Working with these patients does require a lot of patience. Working with these people does require a lot of patience from you. There may be a need to modify the ambulation devices. The person who has had a fear of falling may not be able to use a walking frame. They may need to use parallel bars, or they may need to walk with somebody holding on either side while they get their confidence back, and then gradually work up to whether it be a walking frame or a walker, whether it be crutches, whether it be a cane, but starting with a high level of support. And then we can also, work with people on exercises that don't involve standing, whether it's swimming, whether it's a stationary bicycle, whether it's arm exercises. All these things can help the person create, get more strength without fearing falling. Of course, those arm exercises, sitting down or swimming, won't help the fear of falling, but it will help them get stronger. This is an issue, and I don't know to what degree you're encountering it in your own practices, but it's become a really big problem in the United States. And that is that we have more and more people who are elderly. They maybe have a greater amount of confusion, dementia, and the problem is, especially if they're in a facility where it's not the person's family looking after them, it may be nursing, it may be other staff. The person wants to get up and walk, they're unsteady, they fall down and hurt themselves. And a common reaction from the caregivers is to give the person sedatives so they're less active, or even physically restrain them, putting a tray on a wheelchair, putting bed rails on the side of a bed, maybe even fastening some sort of vest around their body that ties into a chair or ties into a bed. And, the idea is good. I mean, the idea should be good. If the person doesn't walk, therefore they won't fall, and therefore they won't hurt themselves. And also, as I say, it's a really big problem where you have not too many staff. You have a lot of clients and no staff. That's why, a family situation can be better because you're more likely to have family members around. The problem is that when somebody gets fastened into a chair, especially if they have dementia, there's a great increase in confusion and agitation. The person is being fastened in, they don't remember they can't walk, they don't know why they're being tied in. And like any of the rest of us would do, if somebody tied us in a chair, the reaction is, get me out of here. I want to walk, I want to go someplace. And it just creates confusion and agitation. If a person can't get up and walk, they're in much more danger of getting bed sores, decubiti, because they're just sitting for a long time. And they lose their endurance. If they can't walk, they get weaker, less endurance. So once they try and walk, they're more in danger of falling. And also increase incontinence. The person can't get out of their chair to use the toilet. They need help. They need to be unfastened. And, part of the problem is insufficient staff to monitor. So, there's not somebody to take the person to the toilet when they need to go. And the result is they're incontinent in their chair and they get in the habit of being incontinent. So it's a big problem there. And contrary to what some people think, the result of restraining does not seem to be decreased falls and injuries. In fact, this study did a study of different nursing facilities and found there was no difference in the number of falls. And there was actually a reduction in the number of falls that resulted in hospitalization and injury. And part of that is because people are pretty, even with the stage of dementia, if somebody puts you in bed and puts bed rails on either side, and you really need to get to the bathroom to get up, you're not going to just lie there. You're going to climb over those bed rails, and you have further to fall. Or if somebody puts a lap tray in front of your wheelchair, you're going to do all you can to get out from under it, to get over it, and probably have a worse injury than if you just, stood up from the wheelchair, even if you had a problem with falling. So it doesn't really help. But the problem is, again, especially in facilities that have a lot of patients and not that many staff, it's a big problem. Again, this is just some examples of things that people can do and injure themselves while they're trying to get out of these restraints. So some options, of course, the most important thing is to have the individual attention. Having staff aware when a person wants to walk to be able to assist them, being at home with the family where, a grandchild can help the person to walk, making sure you know what's going on with the person. But also activities to decrease boredom. Again, I'm talking mainly about the United States, although to tell you the truth, when we lived in Guyana, there were a couple in South America, there are a couple of nursing facilities there, and the same situation. The staff would get the person up, put them in their chair, and just sit there. Put them in front of the television. The person would fall asleep. They get bored. And, when you're bored, especially if you don't want to sleep, then you get up and try and move around, and that's when a person is more likely to fall. So individual activities. And if somebody does have to be in a chair or a bed, more comfort to reduce pressure. And as I said, assisting with toileting on a regular basis, so the person doesn't become incontinent. There are some interesting mobility devices. One that I remember using a number of years ago, I haven't seen it commercially available. I think it was made by the facility, but it was made out of PVC pipe. It had wheels on it, and it had a bar that the person would sit on. So the person could sit down and rest, or they could walk, but they couldn't get out of this device. So they could go where they wanted to, but they were in the device. And then some places would put a pad next to a bed, so if a person did fall, they wouldn't hurt themselves. My brother lives in a community of older people, and their facility is run by a group called Eden Alternative. And this was a way of decreasing institutional aspect. Many places in the United States will be a long hall with room, 20 rooms on each side of the hall, one nurse who goes up and down, giving medicine, coming back, giving medicine. That is really disruptive for people who are beginning to have some stage of dementia. So this Eden Alternative, what they do is they have more small pods. So they'll have a small area that has 8 clients live there, their rooms are there, they eat together, they have the same staff member looking after them. It's much less an institutional place, and it reduces people's confusion. It reduces people's need to get up and just walk around and go away, and staff are more aware of the individual clients and their needs. So this is something you could look into as a possibility. Again, as I've said, in many traditional societies that people are cared for at home, this is less of a problem. But societies around the world are changing. Children are moving from rural areas into cities. The grandparents are more likely to be at home and by themselves or being put in a facility. So this is a problem we have in the US now, and I'm pretty sure it's going to be a greater problem in other countries as time goes on. So let's look at what we can do. As I said, reducing fall risk is a team effort. Physical therapy, occupational therapy, vision specialist, hearing specialist, excuse me. One thing we can do that's fairly simple, and it's something I would do at people's homes when I was educating family members about fall risk, is this simple timed up and go test, whereby you would have the person sit in the chair, stand up, walk 10 feet, turn around, sit in the chair, return the chair and sit. You would look for things like unsteady gait. You would look for tripping hazards. You would observe these things, but you'd also time them. And this test has been norms developed in the United States for different ages, sexes. In general, though, if a client would take more than 12 seconds to stand up and walk 10 feet and come back, that would indicate a significant fall risk. And you could talk with the family and say, these are some things to look at. So this is one thing. It's a real easy test you can do at home, or you can do in a facility to try and get some idea of if there's a fall risk. We've already talked about a lot of these things. In fact, I think we've already talked about all these things that OTs can do. Positioning devices, walking aids, interest assessment, staff and family education, and advocating for reduced restraint use are things that we as OTs can do to help reduce falls as part of a team. It should be a team effort. So in general, the benefits of OTs for geriatric clients, and these are true for all clients, but more specific for geriatric clients, helping people be more independent. That independence can help to improve their mood and self-esteem, allow them to live at home, whether it be family members or outside an institution for longer, and help the community to support the person. We don't only work with the geriatric client, we work with the family, we work with the community, so they're aware of the needs of the person and they're aware of how to help the person to stay out of the facility. Now, there are some problems that I think some of you who are working in developing countries are going to face. And that is that a large number of the tests that have been done have been developed in Europe, have been developed in the United States, and there have been norms based on the situation in those countries. The Bartel Index, I think most of you are familiar with. It's it's an index that looks at the different activities that somebody needs to do during the course of the day, gives them different emphasis, which are more important. According to this, the mobility in stairs is most important according to this index. Such things as bathing are less important. And then you come up with a score, and then based on that, you can see how a person is doing. You can also see if there's change over time by how those scores are. But the problem is, this is based on a certain culture, a certain place. If you're living in a country where people sit on the floor, then and beds are on the floor, then this transfer bed chair to back will be less important. If you live in a place where houses are on a ground level, then stairs are going to be less important. So these are things that you need to look at in your own countries to see how relevant some of these indexes are. And this is just, I guess, a review of what I've been saying, that the tests may not be relevant, norms are not relevant. And you as OTs, one of your role can be to try and translate some of these, determine if they're relevant, develop norms. The other thing to say, I've worked with clients who are of Japanese descent in nursing homes, elderly clients. And as an OT, I would say, okay, we need to help Mrs. So-and-so, Mrs. Lee, learn to dress herself. And I would often have family members say, but I want to help. My job is to help my mother because my mother helped me. So my job is to help my mother. So I'm going to help her put on her shirt. And often the patients themselves, the elderly patients themselves would say, this is how my daughter shows me she loves me. So we do need to be careful about saying, okay, we're going to help you get independent no matter what. We need to adapt whatever we're doing and think about these cultural norms. So that is what I'd like to say in general about occupational therapy for geriatric patients. The rest of the presentation will be more talking about some diagnoses that are most commonly seen among geriatric patients. I'd like to pause for a minute, rest my voice for a minute. I see that some messages are coming from the chat. If there are any questions, if you'd like to ask questions about what I've done thus far, if you'd like to share your own experiences about some of these issues working with geriatric patients, I would really welcome that. If nothing, go on. If you don't want it, let's go on. So again, here we're going to talk about some of the different possible problems that older people are more likely to have. And one of them is dementia. Basically decreased in cognitive function, decrease in problem solving, decrease in judgment. The one thing to say is that we as OTs don't work with people by themselves. It has to be a team effort. Physical therapy, vision specialists, hearing specialists, psychologists. It needs to be a team effort to help people who have dementia. And we as OTs can work with them, or we can make referrals as needed. I want to talk a little about the Allen Cognitive Scale. This may be something some of you are familiar with, but if not, it's useful. Basically, Claudia Allen, a number of years ago, almost 60 years ago by now, as an OT, observed that people were having trouble working with patients with dementia. And one of the problems was nobody knew what to do for a certain patient. So she tried to come up with a framework to help people identify, what people could do, what they couldn't do, what problems they were having, and what could be done about it. And so what she did was and again, we're focusing on behavior, and then treatment that can come out of the behavior. What she did was she divided people's cognitive level into cognitive function into 6 levels. Each level subdivided in modes, and we'll look at that more later on. So somebody who was at the lowest level, the first mode, had very, very severe cognitive impairment. Maybe, if somebody pokes them with a pin, they would withdraw. But no talking, no movement, no purposeful movement, just almost a vegetative state. So that would be somebody who was at the lowest level. And then somebody who was at the level 6, it would be with normal cognitive function. Somebody who could plan complex activities, who could do whatever they wanted to. And in the middle, you'd have the people who were some memory loss, some people who had trouble dressing, the different aspects. So this is the model that Claudia Allen came up with. You will see on the left side, these different levels. The first person has automatic reactions. As you get more in a higher level of cognition, into postural reactions, all the way up to goal or directed actions, all the way up to planned actions. And then each of these levels is divided into 5 parts, depending on what the person can do. The person at a very low level, all they can do is withdraw from noctus stimuli. Whereas if they're at the high level or the high mode within the level, they may be able to raise one of their body parts. So this is a framework that she came up with. And this is what she used to determine where a person's level was to decide what could be done about it. This is another way of looking at it. Again, we have the 5 levels, although we don't have it divided into modes here, but they're at different levels from the very severe level all the way up to somebody with mild cognitive impairment. And that person who's at the first level is likely to need total cognitive assistance, total physical assistance, whereas the person at the highest level may need supervision with a new task, but no more than that. This chart does talk about comparing with an infant, compare with the child development. And it goes all the way from level 1, an infant, all the way to early teens. It is really important to note that this is for comparison only. So when we're working with a person with dementia, they may be acting as a 2-year-old, but we have to keep in mind they're not a 2-year-old. They have a past history. They were a competent adult. They need to be treated with the respect that they deserve. So Claudia Allen would assess people in different ways. The first way would be by observing what they were doing. Seeing if somebody pinched them, do they withdraw? Seeing if they can grasp objects, seeing if they respect social standards. And then secondly, she had some different craft activities, and based on how a person performed on those craft activities, she would be able to test people in the higher level. You can't use the craft activities for somebody whose only reaction to withdraw is withdrawing from a noxious stimulus, but you can for some of the higher levels. So this is a weaving activity whereby the person would weave these colored strips of ribbon through the papers. And then the leather lacing activity. You'll notice on here there are 3 kinds of lacing. The one on the top left is a very simple over and under, over and under. This one goes from front to back, front to back, front to back. And this is a more complex one. And based on a person's ability to learn these leather lacing activities, Claudia Allen was able to assess what level they were at and what they could do. And then within each mode, there would be some activities that would be appropriate for the client and some cognitive limitations, how the caregivers could help the person get maximized at that level, and what the caregivers could do to help the person to move on to the next level. And this is sort of a summary of that. Again, we have our 6 levels on the left. We have the different interventions that a person could do at these different levels and how much assistance they're going to need. And again, this is just a way of saying, okay, I have a patient based on the assessment, they're at cognitive level 4. So these are some different things I can do with that person, and this is the amount of assistance they're going to need. Again, it varies from person to person, but this is sort of an outline. And this is another way of looking at it. Again, you have your 4 levels all the way from lowest level up to high level. And then their strengths within these different levels, the problems they may encounter, the problems you may encounter, and then some way of helping to care for the person. And just an example, you have a person who's in level 3, mode 6. They can do a task like folding towels independently, but they may get distracted. So if you look at information on this person, the recommendation would be to work with the person in a quiet environment. And you would gradually increase the distraction level if the person could tolerate it, and therefore help them to improve. Now, this Allen Cognitive Scale information, it's complex, and it's not for free on the internet. You have to purchase the kit. There's information on the internet, but in order to get the kit, in order to get the very specific things, you need to it costs about $200 to get the whole information. Let's see, what time is it now?
It's 2 minutes of 2.
2 minutes of 2. I think this is a good stopping place. We've talked about general occupational therapy for geriatric patients, and we've talked about dementia and how you'd work with somebody with dementia using the Allen Cognitive Scale. We do have a few more things to say about dementia, but then next month we would talk more specific about that. We talk about some of the other approaches. One thing I do know is that Dr. Kate will be sending out this PowerPoint to all of you. So if you have any questions, you can look over the whole thing. If there are any questions from the first half, please bring them up next time. If there are any specific questions you come across by looking at the PowerPoint for the second half, those are things we can discuss next time. Does anybody have any things they want to share before we cut off for today or before we go out to our meet and greet?
Well, David, that was fantastic. Thank you so much. And please feel free to bring like a case study. Just change the first name of a patient that you're working with if you'd like to discuss a specific patient next month. Well, thank you so much, David.